Hi, my name is Mike Tuchek. I'd like to discuss a case using the Volcano intravascular ultrasound to do a typical endovascular stent graft for an abdominal aortic aneurysm. On the second slide, you can see that this patient is an 82-year-old male with hypertension, anemia, a history of prostate cancer, high cholesterol, and is an ongoing smoker. He has an aneurysm that is 5.3 by 4.7 centimeters. Slide 3 shows the CAT scan image of the aneurysm. Slide 4 shows the intravascular ultrasound with the 1 centimeter markers that allows you to identify the renal artery takeoff and the internal iliac artery takeoff to get measurements of both diameter and length using minimal fluoro time and no contrast use thus far. Here you can see the intravascular ultrasound pullback in slide 5, which shows the celiac artery, the superior mesenteric artery, and then the renal vein along with the renal arteries taking off at approximately 3 o'clock and 9 o'clock. And then the length and diameter and quality of the aortic neck showing minimal debris and a fair amount of calcium. It then shows the aneurysm itself along with the amount of thrombus, and then the iliac artery quality and diameter down to the internal iliac artery takeoff, and then the diameter of the external iliac artery to decide which side you want to go up with putting in the main body. The next slide shows the right iliac artery diameters easily measured by intravascular ultrasound, confirming or sometimes disputing the CAT scan diameters. The next slide shows the diameter and quality of the aortic neck just below the renal arteries. The next slide shows the mid-distal abdominal aortic neck along with diameters showing that it is slightly reverse funnel. In this slide we ask several questions that can all be answered by intravascular ultrasound with a pullback that takes only a couple of minutes without having used any contrast, using spot fluoro only. For example, what size main body graft should we place? How long is the aortic neck? And how much clot or calcium or debris or even angulation is in that neck and where that is exactly in real time? Where should you land the graft to maximize both fixation and seal? Do you need a graft that has suprarenal fixation? Is there distal neck stenosis immediately above the aneurysmal segment that's going to interfere with the deployment of the gate and our ability to cannulate that gate and prevent any gate or contralateral limb stenosis? Furthermore, in the next slide, thanks to intravascular ultrasound, we can determine how big, long, or angulated and diseased the iliacs are, along with what diameter and length the ipsilateral and contralateral stent graft limbs should be. It tells us if there's any disease in the iliac that needs to be treated before the graft is placed, like placing a small angioplasty balloon in the external iliac arteries in order to facilitate placement of the main body through those stenosed external iliacs. The next slide answers some of those questions with a single pullback It told me that I needed to place a 26 millimeter diameter device that was about 18 centimeters long, placing it just below the renal arteries, which is easily seen using spot fluoro images thanks to the built-in 1 centimeter radio-opaque markers in the IVUS catheter itself. It told me that I had a short neck with a moderate amount of calcium but minimal debris, and so I chose a suprarenal device and considered using the Apta stapling device because it is a fairly short neck here. It gave me all that information without injecting any contrast whatsoever to this point, reducing the overall contrast load for the patient. It also allowed me to reduce the amount of radiation during the patient by only using fluoroscopy to spot check where the transducer was relative to the anatomy of the patient. Thus, before ever placing the device, I have a complete picture of what needs to be done, and I've used no dye and minimal fluoro time, which reduces the overall procedure time significantly. In the next slide regarding the iliacs, it told me that I could place the main body up either the right or the left external iliac artery. It told me I had a choice of using either a 13 or a 16 millimeter diameter iliac stent graft limb, and the exact length of those limbs needed to cover right up to the takeoff of the internal iliac arteries without any dye load being used. And it also told me that I did not need to perform any sort of dilator angioplasty or balloon angioplasty for any significant stenosis in the external or common iliac arteries in order to get the main body of the device in successfully. The next slide shows my initial angiogram. I do a 20 cc for 2-second run, so I use 40 cc's total. But I don't usually do this, but I did so for demonstration purposes, just to see the overall short neck, the aneurysm itself with the thrombus load inside the aneurysm sac, and the iliac arteries. The next slide shows the insertion of the graft itself. The next slide shows the graft deployment, in this case using a Medtronic Endurant device because of the short neck. The next slide demonstrates that we've cannulated the contralateral gate, but if there's any question, we can spin a catheter, or in the next slide simply put up the IVUS and see that we have, without any question, gotten the wire into the correct position inside the contralateral gate. The next slide shows the ease with which you can identify exactly where the internal iliac artery takes off. If you shoot an angiogram, you sometimes aren't sure where the internal takes off. If there's a double density there, it might be higher, etc. But with the IVUS catheter, you know exactly where it takes off. This next slide shows the angiogram, which confirms where the takeoff is, but I usually don't do this if I'm trying to minimize dye. I go based simply on the intravascular ultrasound. I then use the Reliant balloon to balloon both the iliac limbs and the main body of the device. I then do a completion IVUS run to make sure I don't have any issues with the main body having graft infold, or that there's any iliac limb stenosis at the aortoiliac bifurcation or in the iliac arteries themselves. It's surprising to me how often we find iliac stenosis like this, even though the angiogram appears totally normal. If the stenosis takes place in an anterior to posterior geometry, that could only be identified if you move the image intensifier to 90 degrees. Once I've done my final run, again using 20 cc's for 2 seconds, I identify any abnormalities in the graft itself, any endoleaks, make sure there's good renal artery flow, and good internal and external iliac artery flow. In this case, the final angio demonstrated that there were no endoleaks, but there was a hazy area in the right common iliac artery. And you have a choice to either balloon the graft directly or leave it alone, or you can use intravascular ultrasound to identify exactly what the problem is. In this case, in the next slide, you can see that clearly there was an iliac stenosis there. The next slide shows us doing balloon angioplasty and ultimately kissing balloons at the aortoiliac bifurcation. And the next slide shows the intravascular ultrasound run with successful dilation of those two areas. The next IVUS run shows that the other iliac artery limb also has no significant stenoses. This final angiogram run certainly does not identify any iliac limb stenosis that's obvious, and yet that is precisely what we found by intravascular ultrasound. In conclusion, the IVUS catheter helps me in so many ways, including identifying key anatomic landmarks, how much calcium or stenosis or debris is in both the aortic neck and in the iliac arteries, which can be treated at the time of the original operation. In the final slide, it also aids in my key decision making on graft sizing, graft length, and the location and placement of my main body and iliac limbs. Most importantly, it helped me reduce fluoroscopy time significantly, and I use minimal contrast, typically only doing runs around the time of the original graft placement at the renal arteries and the final run to rule out endoleaks. It minimized the need for multiple catheter exchanges for a pigtail marker and all the time spent doing that, along with the additional angiograms to identify, for example, the location of the internal iliac arteries. Thanks very much. I hope this case summary is helpful for you.